Hi everyone, my name is Jeff Dykes with CVTC's EMS team here, and this is Chapter 1 EMS Systems for EMT1 class. Just trying to give you a little bit of a background, a little voiceover, rather than just reading the book. Sometimes hearing it from someone helps sort of connect the pieces and connect the dots and so on and so forth. Um, in the book, it's going to talk about the difference between certification and licensure, and it's important for us to understand this concept. I've got horror stories out there of people who were certified but not licensed and getting hired and so on and so forth. But if you think of it this way, certification makes sure that we all get the same training, make sure that you have passed a course, make sure that you are proficient in the objectives, that you can do what the state needs you to do and wants you to do, but you are not ready to go out and work in the field yet. You are just a certified EMT. You cannot jump on an ambulance and go ride at the local fire department until you are licensed. Think of a certification like a driving test. You go down to the DMV, you take the test, and it's great, but it's not until the state of Wisconsin gives you your license, your Wisconsin driver's license, that you can actually go and drive a car. Just completing the course or the class is not enough. So licensure then is actually working with the state to actually make sure that you can apply your skills and become licensed, similar to like a driver's license. So pass this class, you'll be certified. Pass the National Register, you'll be certified. Take those certifications and apply them for a license with the state of Wisconsin. Now you're a licensed EMT. Big difference. The EMS system is not just ambulance people. It's just not a bunch of ambulances running around. It's much, much bigger than that. It's everything from medical direction to making sure we have the right systems like a trauma system to different entities, making sure that we are doing the right thing in the field by setting protocols and evaluating the calls that we're on and making sure that we stay up to date with the science and the communication, all the way down to the communication department where they're receiving the 911 calls and getting that information out to you, to doing public ed safety fall safety type of features where we get into the community and work with some of the elderly people to make sure that we are prohibiting or being proactive, making sure that they don't fall, or blood pressure checks. There's just so many of them out there. All this stuff has to work together, and we need to make sure that you guys understand that it's a system-wide process. It's just not you're a cog in a very big wheel, a very important cog, but you're a cog in a very big wheel. So how does the whole thing start? Well, someone needs help, right? They determine that they need an ambulance, a fire truck, a police officer, a sheriff's, whatever. They call 911. 80% of the calls that are coming into the comm center these days are on cell phones, which makes it difficult for our dispatchers. Because if they're calling from a landline, they get a lot more information. They get exact location, they get previous call data, they get addresses, so on and so GPS coordinates. With a cell phone, they don't get any of that. There is some advanced systems out there where they can triangulate it, but eventually it's going to end up in the hands of the dispatcher. Some dispatch systems just simply kick out an ambulance or a fire truck or a police officer appropriately. Other ones go through a series of questions that determine exactly what resources you need. So maybe you need an ambulance and a fire truck. Maybe you need an ambulance, fire truck, and a squad car, a police officer. Eventually, they're going to get down to the process of letting us know. As EMTs, we jump in the ambulance, we make sure we know where we're going, we drive safely, we actually expedite our travels there, maybe. You make up your time and how fast you can get to the scene through the process of getting to the rig. And when you get on scene, it's not drive time. Drive time is safety time to make sure we get there appropriately. You drive different speeds depending on the situation at hand, but you'll get stressed enough that throughout this course that driving is a safety concern that we have to make sure we do it appropriately. So you get on scene, you do all your magic, you treat your patient appropriately, you throw them in the back of the ambulance, and you take them to the hospital. And at the hospital, hopefully they're going to receive definitive care, especially if you took them to the right appropriate hospital, right? There's different levels of hospitals, but this is sort of the whole 911 system from a very high level. There's different levels of EMS providers in the state of Wisconsin. We have EMRs, we have EMTs, we have advanced EMTs, and we have paramedics, and then on further to the right would be critical care paramedic as well. But this sort of gives you an overview of what are some things that one entity can do that the other cannot do. So, if you're an EMR, it's assisting an EMT. You can get some vital signs. You can do some bleeding control. but you're there more in an assist role. You're not really in the ambulance. You're assisting the people that are coming on the ambulance. Once you get to the EMT level, then you're allowed to do some additional things. It's about 160 hours roughly of training, but you carry a handful of different medications with you. You can do some airway adjuncts, which means we can put tubes down people's throats and help them breathe. We can shock them like you see on TV, and just a whole litany of other skills that come along with the BLS level. Once you graduate then into the advanced EMT level, then you can start doing IVs. You get quite a few more medications than the EMT basic does, but that's another, 200 hours or so. Oftentimes, if you're looking to advance your career, you go straight from EMT to paramedic. There's nothing that says that you have to acquire the advanced EMT first. But once you get into paramedic, you see a huge jump in hours. You're well over 1,000 hours, and that's probably on the low end. This is where you're actually putting tubes, visualizing tubes going straight into the lungs. You get very many medications, everything from sticking needles into people's chests to starting IVs. DFAM is where we take away the person's ability to breathe and we take over their airway for them. So there's some pretty high advanced stuff as a paramedic, and then you can just about imagine what a critical care paramedic can do. Additional skills and certainly additional medications as well. So the healthcare system, you have the ER, obviously that's where we're going to take people, but sometimes people don't need to go to the ER. Sometimes they need to go straight to the trauma center. We have specific burn centers. We have specific pediatric centers. We are moving very quickly into home healthcare, where EMTs and paramedics are going into the home of recently released patients from a hospital and providing on-scene care with no intentions of taking them to the hospital, which is sort of that community paramedic work. And then you have the urgent care clinics, which is where a lot of people can get some low level care and diagnosis and sort of weed out some of those lower urgent calls, so we're not over inundating our ERs with non-emergent situations. So a lot of different options. You need to know where each one of these are in your area, and you will as you start riding the ambulance. So what are your roles and responsibilities? You're going to hear this over and over and over again. Your own personal safety is priority number one. You can't do anyone else any good if you are not safe yourself, or even worse, you become part of the problem. After you have ensured your own safety, then you have to ensure the safety of your patient and your crew and your bystanders. So that's sort of that next layer of the onion, if you will. You have to have some scene leadership. People are calling you in a time of need. They're calling 911 on a hopefully very infrequent basis. So when you show up, they're expecting you to do some good work. They're expecting you to provide good scene leadership. That can be everything from turning off the TV to giving them some privacy and getting other people out of the way, and then obviously providing good patient care on top of that. And you can't provide good patient care unless you do a good patient assessment. You can be the best blood pressure taker, best splinter, best massager, whatever. If you can't figure out what's wrong with a patient, you can never get to those skills anyway. So you have to be a very good patient assessment clinician. And then based on your assessment, then you start figuring out, okay, well, based on the findings that I just found during my assessment, this is what I think I need to do for this particular patient. So they all sort of go hand in hand, but it always starts with your own safety. If you are not reasonably safe on that call, you need to get out. Additional stuff, you're going to supply emotional support to the patient, to the family, to your crew members. You're going to see some stuff that is not super great, people dying, blood, so on and so forth. Again, you being able to provide that emotional support is very important. You're obviously going to be lifting and moving patients. The goal here is to transport them to the hospital, but also to coordinate that transport to the hospital with the hospital that's receiving, other ALS crews, law enforcement, so on and so forth. You just can't grab a patient, run them off to the hospital, and leave the police officers wondering where did that person just go. You're part of this process of making sure that everything runs smoothly, and that just comes with time and experience. One of my favorite terminologies here is patient advocacy. I'm an advocate for my patient. What is right for my patient? Are they going to the right hospital? Are they being manipulated by someone else unseen? When I go there, I'm treating them as if they were my own mother, my own daughter, my own wife type of thing. Personal accountability is huge. You will be given opportunities in this career to do a variety of things that are unethical, from money laying around to where the house keys are that are stashed underneath the rock, and so on and so forth. If you can't provide that integrity within yourself, then this is definitely not the career for you. EMTs, paramedics, firefighters, police officers have built up this persona in our community as being very integrous. We are held to a high standard, but it only takes one or two of us to do something stupid to tear that all down. You read an article in the paper about an EMT who ends up stealing money from a patient. Well, guess what? All the EMTs in that particular service, and probably all the EMTs in that region, are going to get a black eye because of it, because of one person's poor choices. Then we have continuing education. I love it when people say, I can't wait till I take the National Registry test, then I'm done. No, you're not. I've been doing this for 24 years and I still am required and need to go back and do continuing education. Science changes, things get updated. You need to stay on top of that. If you're not staying on top of those changes, then you're not doing your patient any good. I think back to how I treated a patient just 10 years ago compared to how we treat them now. It's completely different and it's based on science. So every couple of years you go in and you get the updates. And then skill proficiency. You need to stay on top of your skills. So because you learned how to sling and swath a broken arm today does not mean you'll know how to do it in a year from now. You lose those things. So how do you maintain them? Well, you practice them. There's a great slide I have in one of my other courses. It talks about sweeping the floor. It says if you sweep the floor today, the floor is clean, right? So does that mean you never have to sweep your floor again? Well, no. Do you have to sweep it tomorrow? Probably not. It's probably still clean unless someone muddied it up. But over the course of 4, 5, 6, 10, 12, 15 days, the floor becomes dirty again and you need to sweep it again. So I view training the same way. You train today, you need to train on that same topic again at a later date. Otherwise, it just becomes muddy, dirty, blurry, and you don't become very proficient in it. The patient safety, do no harm. So that is one of our mantras in EMS is that when we don't know what else to do, just don't do something bad. Don't leave the patient any worse than you found them. And you can do that in a variety of ways, from bad communication to actually causing injury to the patient, to manipulating the spinal injury, to crashing an ambulance, or sometimes it's just you didn't do a good patient assessment and you missed something. Sometimes it is just you didn't know what to do, so you guessed. These are just not things that you should do and will not be tolerated in the EMS world. So do no harm, do no harm, do no harm. But sometimes things happen and it becomes, we always dig into why. Why did it happen? Well, sometimes you're just not good at that particular skill. You couldn't start an IV. You weren't good at splinting that. You didn't know how the stair chair worked. You didn't know how the cot worked. You just have a failure in your skills and knowledge. Well, that's sort of on you. You gotta work on those skills. Sometimes you just don't know what the rules are. Well, I thought I could give that patient that medication. Well, no, you can't because it's not in your protocols. So knowing what the rules are is another way that we sometimes can do harm. And the other one is just a knowledge failure. Just say, I didn't know that that's what a defibrillator looked like. I did not know that when that patient told me that they're on this medication, I didn't know that medication meant X, Y, and Z. So these are things that are sort of on our end that we can work on our skills. We have to make sure we know our protocols and we can keep on top of our knowledge base. So how do we prevent some of that stuff from happening? Well, clear, precise protocols with good training are a good one. That's a high standard to make sure that we're all working off the same sheet of music. Something as simple as lighting. God, man, in the back of the ambulance in the side of a ditch in someone's front living room and you don't have good lighting, something as simple as that can really contribute to potential errors. Minimizing distractions, turning off the TV, making sure you're focused, making sure you are mentally ready for that particular call. Or as simple as organized meds. You open up someone's med kits on the ambulance and there's just, looks like a grocery bag just full of junk in there and you're digging through trying to find that one vial that says epinephrine. Well, if you had it organized and it's in the same place and it's nice and neat, that's a way to prevent possible injury. And then when you look at it from an individual standpoint, how good am I? Did I do good on that call? Could I have done better? What would I have done differently given the information at the time? Was I tunnel vision? could I possibly reevaluate some of those assumptions I had? Tunnel vision is where you walk in, you see the patient, you're like, this is what's wrong with them, and this is the only thing that's possibly wrong with them, so this is how I'm going to treat them. And you don't look for the other possibilities out there. And sometimes that goes sideways, and in retrospect, you find 5 different things that you should have seen that you missed because you were so tunnel vision. There's lots of different resources out there uh, from medical control. So if you're taking a hospital to XYZ, you've taken a patient to XYZ ER, there's a doctor there with a phone on their hip waiting for your call that can answer questions for you. Maybe it's a flip chart. Maybe it's a protocol book. There's stuff available to you in the back of the ambulance that you do not have to make this stuff up on your own, nor should you. If you don't know the answer, find the answer. And if you don't have a clue of what you're doing, or you found yourself in a very unique call that just nothing adds up, and trust me, I don't care how long you've been doing this, it's going to happen to you. Ask for help. You call that doctor and you say, this is what I see, this is what I understand, this is my level of training, help. Like, what do you want me to do? Because essentially you are an extension of their medical license, and we're going to talk about that here in future chapters here as well. So personal attributes, look the part. Don't come in all grungy, hair messed up, bad breath, torn clothes, so on and so forth. You need to present a professional mannerism. When you walk into someone's house, they want to look at you and go, that guy looks like he's got his stuff together. I'm going to listen to what he has to say. Be self-motivated. Find the articles. Go to the webinars. Listen to what people are saying. This is not something that your ambulance director or fire chief has to hold your hand and force you into a course. This is something you can do, and it's readily available, guys. It's on the internet all over the place. So take it upon yourself. Empathy. Oh, gosh. Empathy is huge in EMS. Empathy is your ability to emphasize with your patient, putting yourself in their shoes. You'd be surprised that out of all, integrity and empathy are number 1 and number 2 in my book. So yes, I'm going to do the right thing. I'm going to be honest. I'm going to hold myself to a high degree of accountability, but I'm going to be able to empathize with my patient. So they know that I feel for them. They know that I have their best interests at heart. You can be a pretty poor EMT. You can do a pretty poor assessment, but if you show integrity and empathy, most of the time, that patient is going to relate with you and be happy with the patient care that you provide them. The self-confidence one is fun. The term that we always use is fake it till you make it. If you walk in there and just do a bunch of ums, ahs, ees, I'm not really sure, all this stuff is going to suck that confidence out of your patient. You go in there and you're bright-eyed, you get down their level, you talk to them and say, hey, my name is Jeff, I'm with the ambulance, I'm here to help you today. And we're not going to lie to them, but at the same time, I'm going to show them that I'm confident. I've done this before. I feel pretty confident in what I'm doing. You fake it till you make it, and then you call for help. Time management and teamwork, make sure you're using your crews appropriately. We're not going to sit there on scene all day long. If you need to get going because of the call requires it, then get going. And then use your team. And your team can be anything from your ambulance director to your chief to the online medical control, so on and so forth. So some key definitions that came out of your book on quality improvement, or QI, is where people are taking a look at your run reports and saying, this is what you could have done better. This is what you did really well. But more importantly, if it's a unique call and 2 of you were on that call, there's probably another 20 to 40 people on your service that could benefit from hearing your story and benefit from what you did right and what you did wrong. We can learn from each other's mistakes, and that comes through a QI program. Medical direction. This is one you should really pay attention to here, because you see this on all the tests. So you are essentially extension of the medical director. So you have a medical director, one particular doctor who writes the protocols for your ambulance service or your fire department. You are working underneath their license. It is mandatory. You have to have one. So if you don't know who your medical director is, figure out who your medical director is. That medical director will write offline protocols, standing orders, that if you see this, you do that. If you see that, you do this. and they're in a book, sometimes they're in a phone app, and they walk you through exactly what should happen if you find someone with shortness of breath with what lung sounds. This is what you should do. Those are readily available to you, and you have to have those memorized, and if you don't have them memorized, you should know where you have to find them. That comes from your medical director. But then you also have online medical direction. Now that is a doctor at the receiving hospital in the emergency room that carries a phone with them. So if I'm taking someone into Mayo ER here in Eau Claire, I would call the Mayo medical director. There's a line, there's a number that's going to be provided to you, and you say, "Hey, my name is Jeff. I'm on Medic 5, and this is what I have going on, and I'm looking for some direction." And you may or may not know who that person is. They certainly probably don't know who you are. And you tell them what your level of care is, and they're going to help you walk through the process and tell you what to do. So that's online medical direction. You can call them on the radio, or you can talk to them on a telephone. Offline medical direction are your protocols and standing orders from your medical director. We get that one wrong a lot. So it's important for you to understand the difference between the two. And then you have some public health stuff that we talk about, vaccinations, clean drinking water, making sure, if there's an outbreak of bird flu or influenza or something like that, we as EMTs are sort of on that front line to say, yeah, we've seen this, quite a bit in the past. We're part of the public health network to make sure that we see these things coming and we can be proactive with them. Making sure people have access to medical care, prenatal care, healthy lifestyle. So, people are... I can remember years ago when I would pick up young ladies who are pregnant and they're smoking a cigarette and they're drinking alcohol. And there's a fine line between educating them and scolding them, but at the same time, part of our job is to make sure that people understand what healthy lifestyles are. And last but not least, in addition to that public health partnership, you'll do a lot of these things where you're doing fall prevention, maybe checking kids for car seats, helping with vaccination clinics, making sure proper PPE is taken into account at various different sites. You'll oftentimes have people just knock on your ambulance housing door, the fire station door, and ask for their blood pressure to be done. That takes quite a bit. You get quite a bit of those requests. And then just the disease surveillance as talked about before. So that's sort of your chapter 1